Good evening to all the aspirants present here. Today's topic is organ donation and transplant, and the speaker that we have here is Dr. Varun Arora, who is a consultant at BLK Max Hospital, Delhi. Thank you, sir. So you may start the session.
Thank you, Sana. Good evening, everyone. So, before going into organ donation and transplantation, first we will understand what is brain death. And we have to understand brain death in European context and not in Indian context. Though the principle 95% of the principles are same for both India and Europe, but since all of you are EDIC aspirants and you are giving EDIC exam, so we have to consider certain things in European context and not in Indian context. So first we'll go with the definition of brain death in European context and what is the criteria, what are the criteria for defining death in a patient. It should be noted and it is important and you will be asked that once the diagnosis of brain death is made in a patient, the patient is considered as legally dead and the focus of management shifts from the patient to organ management. Now the patient is not managed, but the organs are managed because we need to transplant these organs to someone else. The diagnostic criteria, as I've already told you, for defining and for diagnosis of death vary across European countries. I'll be mostly covering about the UK part. It as it is because it is difficult to cover all the European nations and EDIC people they focus mostly on the UK guidelines. There is importance of precise neurological assessment, especially for diagnosing death, and there are ethical considerations in death determination. We are going to see it. So in UK, there was a 2008 code, and now they have upgraded to 2025 code, which was released this year on 1st of Jan. So the diagnostic criteria for the confirmation of death was given in this code. There is only one definition of death, but there are three sets of diagnostic criteria. They have added one more somatic criteria. Earlier, there used to be only circulatory and neurological criteria, and now there are three criteria that is somatic, circulatory, and neurological. So, somatic criteria are used following overwhelming physical trauma or when death is suspected to have occurred considerable time before. For example, the patient is decapitated. Obviously, you will not look for circulatory or neurological criteria. The patient is considered as dead. And if the patient has got rigor mortis, so you see that the death has occurred a considerable time before. So this somatic criteria was added in 2025 code this year. So you may get some questions on this. In 2008 criteria, the circulatory and neurological criteria were there and they have been kept as before. So circulatory criteria are used following cardiorespiratory arrest, most commonly in a case of community setting when death is expected, but also in cases of sudden and unexpected cardiorespiratory arrest where resuscitation has been unsuccessful. So in ICU, you can have cardiorespiratory arrest. You have done the resuscitation, but it was not successful. So you will say that the patient has got circulatory arrest or circulatory death. Neurological criteria is used for brain dead patients. They are used following devastating brain injury in patients on an intensive care unit who remain deeply comatose, have absent brainstem reflexes, and are apneic, with their lungs being mechanically ventilated, but in whom circulation and other bodily functions persist. So you have your organs are working fine, but your brainstem is not working. So that patient is considered as dead, and we have to perform certain tests before labeling this patient as brain dead. So I'll discuss about all these tests. What are the tests for brainstem reflexes? What is apnea test and how it is performed? Before using any of these diagnostic criteria, the competent individual diagnosing and confirming death must be satisfied that there are no further appropriate therapeutic options left which could benefit this patient. In Europe, the doctor is not the one who diagnoses. The, the person can be a doctor, but it is not mandatory like India that only a doctor can diagnose. Anyone who has got knowledge, who is competent enough, can diagnose the patient as dead, especially in cases of somatic and circulatory arrest. However, for neurological criteria, you require two doctors as per the European guidelines. So, when correctly applied and satisfied each set of criteria distinctly, you can say that the patient is dead. I have mentioned the definition of death in my last para, that permanent cessation along with of consciousness combined with permanent loss of the capacity to breathe due to permanent cessation of the brainstem. So I'll be mostly covering about the neurological criteria. I have touched upon the somatic and circulatory criteria. They are pretty easy to understand. So neurological criteria is used when death is suspected to have occurred in patients following a devastating brain injury who remain deeply comatose. That is, their GCS will be less than 3. Or sorry, GCS will be 3, not less than 3. The minimum GCS is 3. They have no observed brainstem reflexes and are apneic, with their lungs being mechanically ventilated, but in whom circulation and other bodily functions persist. So the confirmation is a clinical diagnosis that should be made by at least two doctors who have full registration with the GMC for more than 5 years and are competent to diagnose and confirm death using neurological criteria in the UK. And one of these doctors should be a consultant. So this is very important for somatic and circulatory death. You don't require a doctor. Any competent person can diagnose. But for neurological criteria, in UK, you require two doctors and one of the doctors must be a consultant. Those diagnosing and confirming death should not be acting on behalf of the organ retrieval and transplant service. This is very important. This was asked in one of the questions. And they must not be involved in allocation of any of the patient's organs or tissues that may be subsequently be donated for transplantation. So they should not be a part of organ retrieval and transplant service, and they must not be involved with the allocation of the organs, like this organ will go to this person. This is applicable in India too. So American Association of Neurology, they define brain death with three cardinal signs. First is cessation of function of brain, including brainstem. Second is coma, that is unresponsiveness. And third is apnea. So for brainstem diagnosis, we need to have absent brainstem reflexes, and there are six brainstem reflexes. You must be knowing all these six brainstem reflexes because this can be asked in one of your questions that this reflex was absent, but that reflex is not a part of brainstem reflexes, so you cannot label the patient as brainstem death. So all these six brainstem reflexes should be absent, not just three or four, all the six. Absent bilateral pupillary light reflex, absent bilateral corneal reflex, absent Doll's eye movement or oculocephalic reflex, absent oculovestibular reflex, absent pharyngeal reflex, that is the gag reflex, and absent laryngeal reflex, that is the cough reflex. I'm not going into the details of all these brainstem reflexes, but these six brainstem reflexes should be absent. The diagnosis of brain death is clinical and confirmed by apnea testing. This should be performed twice. Now, in India, there are guidelines that you need to perform this apnea test 6 hours apart. But there is no mention of time in European guidelines. You just have to perform this apnea test twice. And before both these tests, you have to uh, achieve certain prerequisites. Once your apnea test is positive, that means your patient is brain dead. There are certain ancillary tests also. They should be performed when a comprehensive neurological examination, including apnea test, is either not possible or had to be aborted because of certain logistical reasons. So for at that point of time, you need to have these ancillary tests also. And in certain court cases also, you have to have this ancillary test as per European guidelines. So what are the ancillary tests which are available? DSA. In DSA, we will have absence of intracerebral filling at level of carotid bifurcation or vertebral arteries. CT angiography, which is safe. Then transcranial Doppler, where we have presence of diastolic reverberation flow with little or no forward flow. This is the diagnostic. And in EEG, from 18 to 20 channels, if we do for 30 minutes, there is isoelectric recording. All these are ancillary tests, which may be sometimes required along with your apnea testing. So if the apnea test can be performed and if the patient breathes during the test, then the diagnosis of death using neurological criteria cannot be made because the patient has a breath. The patient is not dead. Your apnea test is negative. If the apnea test cannot be performed, there are certain challenges or your prerequisites are not made, then the diagnosis of death using neurological criteria can only be made by confirming both the absence of brainstem reflexes and by the addition of an ancillary investigation. So this is very important where your apnea test cannot be performed because patient may be having some cardiac or respiratory insufficiency. He or she must be on very high dose of vasopressor. So there are certain prerequisites for apnea test. The most important is exclusion of potentially reversible factors like temperature should be more than 36 degrees Celsius. If your patient is hypothermic, he may behave like he is brain dead, but he is not brain dead. So you have to maintain certain parameters above the baseline, like your temperature should be above 36 degrees Celsius. He should not be on any depressant drugs. There should be no sedation. No neuromuscular blockers should be there. Sodium levels between 125 to 160. Potassium should be more than 2 millimoles per liter. If your potassium is less than 2, say if it is 1 millimoles per liter, I am using millimoles per liter and not milliequivalents like we use in India because you will get millimoles per liter in your examination. So potassium, if your value is 1, he may be into hypokalemic periodic paralysis. He may not move at all. He is into respiratory insufficiency, respiratory depression. So he will not show any breaths. You cannot label this patient as brain dead. So you have to maintain your electrolyte parameters, your pH into normal range. So potassium should be above 2 millimoles per liter, phosphate and magnesium between 0.5 to 3 millimoles per liter, glucose between 3 to 20 millimoles per liter. Now, I've specifically given glucose 3 to 20 millimoles because you will get millimoles. Sometimes you will get in your mg by dl, which you get in India. So you have to multiply by 18. So 3 into 18, roughly 54. So your glucose between 50 and your 20 into 18 comes around 500. It is not exactly 500. So your glucose level should be between 50 to 500 because if they are more than 500, patient can be into DK or HHS. He or she should have stable cardiac and respiratory parameters. There should not be severe endocrine disturbances like myxedema, thyroid storm, or Addisonian crisis. So you have to rule out all these conditions before proceeding for apnea testing. Now, once you have made your apnea test is positive, you are contemplating that the patient can is fit for organ donation. There are certain criteria for organ donation. So donor age, as per the American guidelines, the absolute contraindication is more than 80 years. There are no such guidelines in India. In Europe also, there are different guidelines among different countries, but absolute contraindication in most of the countries is more than 80 years. There are organ-specific relative contraindication like lungs, heart, more than 60. In UK, they take more than 50. So they vary according to countries. There should not be any malignancy with high potential for recurrent or metastatic disease. So you can get a K-type question like in which of these conditions you will uh, look for the organ donation or organ transplantation. So you will have to rule out all the conditions where there is a potential for recurrent or metastatic disease. Only in benign conditions confined to a solitary organ, you can actually transplant the organs of that patient to another patient. There should not be any significant system specific disease like SLE. The only major absolute contraindication is sepsis. So there should not be no donor sepsis. So only major absolute contraindication for organ donation is overwhelming sepsis, either bacterial or fungal. The cause of death should not be due to massive poisoning with potential for transplant organ malfunction. In most of the poisoning cases, you will have either liver or kidney malfunction, so you cannot transplant these organs to a healthy patient. And there are certain relative contraindications. There should not be primary brain tumors and no significant infectious disease, including HIV, hepatitis, syphilis, and toxoplasma. You can transplant patients of a HIV donor to a HIV recipient. You can transplant organs of a hepatitis C donor to a hepatitis C recipient, but not to a patient who doesn't have these infectious contraindications. So all these are relative contraindications and not absolute. But make sure that you transplant the HIV organs only to a patient having HIV. There have been cases reported, especially from European countries. Now, before proceeding for donation, there should be ethical framework which can be asked you. There are three fundamental ethical principles: respect for patient autonomy, what the patient has said. Now, in the next slide, I'll discuss about the opt-in and opt-out system which are practiced in European countries. So, respect for patient autonomy. There should be fairness in organ allocation. You have to involve the authorities, whatever the authority of that country is there, for fairness in organ allocation and protecting donor and recipient rights. So, consent models in Europe. Since all of you are appearing for EDIC examination, we are discussing about the consent models in Europe. So, there are two primary consent approaches, the opt-in system and the opt-out system. So, in India, like we have got a opt-in system where the patient has to opt in for the organ donation. Even if the patient was living, he may have a donor card. He may have he or she should have opted for the organ donation. It is not implied, but in most of the European countries now there is opt-out system. In England also, all the adults in England are now considered to have agreed to be an organ donor when they die, unless they have recorded a decision not to be part of donation in one of the, or they are in one of the excluded groups. So they have to sign that they are not willing for the organ donation. Otherwise, every adult in England is considered to be an organ donor. There are variations across different European countries, and family is always a part of decision making. You should always involve the family in decision making. So, what is the role of ICU healthcare professional? Identifying the potential donors. You have to exclude certain conditions, like I said, malignant disease or sepsis. You have to maintain the organ viability once you have diagnosed the patient as brain dead. So, you need to perform and do certain procedures. You have to maintain the physiology of the patient. You have to maintain the hemodynamics, optimize the pulmonary functions, provide compassionate family communication. This was also added in 2025 UK code. Earlier, the family communication was not there. Now you have to always communicate before apnea test, before in between the two apnea tests, that the first apnea test was positive and I'm going to perform my second apnea test. You have to communicate regarding the organ donation process also, like what will be taken. All these things are added in this year in the family communication part. And always there is a multidisciplinary coordination. You have to uh, coordinate between certain teams like transplant, the person who manages the transplant coordinator, the team who is coming to retrieve the organs, the OT team, the primary under whom the patient is admitted, And there are certain ethical communication strategies also, which involves the family of the brain dead person. Now we have discussed about the brain dead patient. What about the donation after circulatory death? Now the heart has ceased. So there are certain definition and processes. I'm going to go into that, types of DCD protocols, ethical considerations after the circulatory death, what are the surgical and medical challenges, and European DCD guidelines. So first, the categorization of DCD donors, which can be asked. So this is defined as Maastricht category. So in Maastricht category 1 and 2, there are uncontrolled DCD donors. In category 1, they are found dead, 1A out of hospital, 1B in hospital. But the cardiac arrest was not witnessed. In category 2, there is witnessed cardiac arrest. The death was in front of the doctors or the nurses, that is the hospital staff. So 2A out of hospital, 2B in hospital. Now, 3, 4, 5 are controlled DCD donors. In your MCQ booklet, Bennington, they have asked about the category 3 and 4. So, category 3 is withdrawal of life sustaining treatment with expected cardiac arrest. So, once you withdraw your life sustaining treatment, patient will land into cardiac arrest. That is category 3. Category 4, cardiac arrest while the patient is brain dead. Patient is already brain dead, you are awaiting for all the formalities and to be completed, and you are maintaining all the perfusion to all the vital organs, and the patient goes into cardiac arrest. So that is DCD category 4. Category 5 is euthanasia. It is not legal in UK, but it is legal in certain European countries. In India also, it is not legal. Euthanasia as of now in UK and India, it is not legal. So I'm not going to, they will obviously not ask for any of the questions on this category 5. Nomenclature of time periods. There are certain time periods. So functional warm ischemia time starts when the systolic BP has a sustained fall below 50 millimeters of mercury for at least 2 minutes and extends up to the onset of cold in situ perfusion or normothermic regional perfusion. So this, you have to mug it up, this definition. Cold ischemia time extends from initiation of cold perfusion until restoration of warm circulation after transplantation. So this warm ischemia time, it increases in death after circulatory donation after circulatory death in comparison to donation after brainstem death, because after brainstem death, that is a brain dead, your heart is beating. So obviously your warm ischemia time increases in DCD. As per UK BTS guidelines, I'm adding this slide. This is only meant for UK law, ethics, and donor consent. So overall benefit should be the guiding principle when making decisions about end of life care in relation to organ donation. This is very important because it has been asked, what is this overall benefit, that there should be benefit of all the recipients as well as about the family of the patient. It doesn't involve any monetary transaction, but the family should feel that they have done a good cause. So overall benefit should be there. The strength of the patient wishes and decisions regarding organ donation should be included in any consideration of overall benefit. If the patient has said that he or she doesn't want to donate, if he has opted out, then we should respect the decision. This is very important and it has been asked. You will not say that it is an implied consent that the patient has donated. No. It should not be assumed that someone opting into organ donation necessarily has a stronger wish to donate their organs than someone who did not record a performance. So this should be also taken into consideration. And further consideration is given to ethical considerations relating to the undertaking organ donation research. So if you are doing something for the research purposes, you have to take the consent for such activities. Now, management of the organ donor. So this is very long. You have to read it a lot. I am discussing about only about the general basic principles. First is the general critical care. You have to maintain the nutrition of the patient. You have to keep him propped up. You have to clean with fluoxetine. Whatever general supportive critical care you do it in every patient. This is the first thing. Then investigations. Before proceeding for organ donation, you have to do certain basic investigations like CBC, RFT, LKFT, PTINR, and certain higher investigations also to rule out any infectious pathology and to rule out any malignancy. So you'll go for all your test like HIV, hepatitis C, hepatitis B, and certain uh, malignancy parameters also like prostate specific antigen in a male patient, and then your alpha fetoprotein to rule out the colon carcinoma, your basic chest X-ray, abdominal ultrasound, CT scan, then fluids, electrolyte, and nutrition. You have to give a balanced maintenance solution to all your patients. Maintain MAP above 65 millimeters of mercury. Maintain your all electrolytes between normal ranges to avoid the organ dysfunctions. You have to give this patient adequate nutrition, especially enteral nutrition. If enteral nutrition is contraindicated because of any reason, you can start your patient on total parenteral nutrition, but enteral nutrition is preferred in a patient who is going for organ donation. Temperature management, maintain more than 35 degrees Celsius. If you're not maintaining, if the patient goes into hypothermia, he can develop arrhythmias and decreased cardiac output, and your organ function will be hampered. You need to anticipate autonomic storm in this patient. Patient can go into um, increased BP followed by vasodilatation. So to prevent this autonomic storm, you need to give these patients methylprednisolone. So always go for invasive hemodynamic monitoring in this patient. Lung protective strategies, maintain PEEP between 5 to 10. Go for bronchoscopic toileting if you are anticipating secretions or VAP. Maintain your saturation above 90 and PO2 above 60. Always follow rule of 100 with inotropes, vasopressors, and cardiovascular system. Optimizing hemodynamics is very important. Maintain a SBP above 100. Maintain urine output above 100 ml per hour. It is just a rule. And endocrine management, including glucose management. These patients can go into hyperglycemia because of deficiency of insulin. So always go for glucose management and try to keep your glucose levels between 140 to 180 as you keep in all your ICU patients. And most importantly, don't forget that you need to counsel the family members, especially in European context. Although this is very important in Indian context also, that you need to inform your family members like what are the results, what are your you have performed certain neurological tests, what are its results, why you are doing it, what are the benefits. Always inform them about the apnea test results, like first apnea test is this and second apnea test is this. So going further into brain death may cause cardiac dysfunction and vasodilatation. So go for volume expansion. You need to use your either crystalloids or colloids to maintain a MAP above 65 millimeters of mercury and a urine output of more than 1 ml per kg per hour. If you have a center line, maintain CVP above 12 millimeters of mercury. Use your inotropes and chronotropic agents judiciously to maintain your targets. But don't forget that hypervolemia can also be dangerous. So you need to titrate your inotropic and chronotropic agents and your fluids to achieve a euvolemic status. Hormone replacement therapy in a brain dead patient is very important. You need to give a triple therapy of thyroid hormone, methylprednisolone, and vasopressin, and also insulin to prevent the hyperglycemia. These patients can land into hyperglycemia because of the deficiency of insulin. In most of the articles, you will see that the vasopressin is the vasopressor of choice. It is not. Norepinephrine is the primary vasopressor of choice in a brain dead patient. However, avoid its high dose. Whenever you are reaching high dose, then you can add vasopressin in refractory cases. Vasopressin especially helps, but it is not a primary vasopressor of choice. How vasopressin helps? Because it is the posterior pituitary whose function loses early. So patient can have DI also. Cause of polyuria in a brain dead patient is multifactorial. It can be due to physiological criteria, psychological criteria as multifactorial, or actual DI where the posterior pituitary function is lost. So treat DI with hypotonic saline or D5, and in refractory cases, you may require vasopressin or desmopressin nasal spray. Vasopressin subcutaneous or desmopressin nasal spray. Then you need to optimize your pulmonary function, prevent atelectasis, pneumonia, and pulmonary edema. Pulmonary edema in brain dead patient is due to systemic inflammatory and neurogenic responses. Whenever required, you can go for bronchoscopy for toileting and maintain PEEP between 5 to 10 centimeters of water. Higher PEEP impairs venous return and can compromise your uh, uh, lung function and heart function, especially if you are uh, contemplating this patient for lung transplant or heart transplant. Maintain PCO2 at 40 to 45 and PO2 above 60 millimeters of mercury. So you have to maintain basically the physiology. If your glucose levels are not maintained, then how will you going to transplant the pancreas and the kidney, which gets damaged very easily if the patient has hyperglycemia. So always maintain the physiological parameters in a brain dead patient. You have to focus on the organs, not on the patient now. So I think this is my last slide. Any questions which you want to ask? Sana,
Yes, sir.
any questions? I can answer, or you can share my number with them. I can answer them later on.
Sure, sir. I will put it in the.
This is more of a topic in which you don't have to apply any logic. You have to remember certain terms, how to perform the apnea test that you can read. I have not gone into detail of the apnea test. What are the prerequisites? I've just gone into prerequisites. You have to give 100% oxygen for 8 to 10 minutes. You have to connect the CPAP ventilator. So all these tests you have to, it cannot be covered in a PPT slide. You have to mug it up. I understand this is a boring topic, but you will get 2 to 3 questions on organ donation and transplantation. Any questions?
Aspirants, if you have any question, you may discuss it right now.
Okay, all the best to all the aspirants. I hope I am able to. Someone has asked, how do we do apnea test in a patient with severe ARDS? So we have to, like I told you, we have to maintain cardiac and respiratory your parameters within a normal range. If a patient has got severe ARDS, you won't be able to maintain saturation, what is required above 88%. And once you disconnect the patient, you will have to abort your apnea test because patient suddenly goes, patient may develop arrhythmias and go into hypoxemia. So in that case, you have to abort your apnea test. You won't be able to perform this apnea test. And anyways, all these patients have high CO2. So you'll not be able to see the CO2. We maintain permissive hypercapnia in ARDS patients. So for apnea testing, we have to have our pH above 7.2. We have to have our saturation above 88%. So severe ARDS apnea testing is not possible, and that is why in European guidelines they say that once your apnea test is not possible for diagnosing brain dead, you have to have your absent brainstem reflexes, all the 6 brainstem reflexes, along with positive ancillary test. So in severe ARDS, you cannot perform apnea test. Patient will land up into severe hypoxia. Any other question? Okay, my best wishes to all the EDIC aspirants. Thank you, Sana.
Thank you very much, doctor.
Thank you, sir. Sir, if possible, the next session we'll have in Q&A session of this topic.
Yes, yes, yes.
Sure, sir. Thank you.
Okay.